Hi, you're watching Nursing. Today we're going to be talking about gastrointestinal emergencies for the paramedic, and this is part of our pediatric summer lecture series. So typically we get called for gastrointestinal related emergencies for things like aspiration, dehydration, pain, and altered elimination. Children with problems of the GI tract are at risk also for nutritional deficits, impaired elimination, and altered body image. Because of their small plasma volumes, children, especially infants, are prone to dehydration and complications of fluid and electrolyte imbalances. Some of our pediatric patients that we'll come in contact with will have a condition called failure to thrive. This is a sign of inadequate growth resulting from the inability to obtain or use calories required for growth. And the definition is any child whose weight falls below the 5th percentile for their age. And we see this in children who have gastrointestinal problems as well as congenital defects, especially cardiovascular and respiratory defects. When we think about the GI tract, we definitely think about, the oropharynx and the esophagus. And so malformations, cleft facial malformations, so whether it's cleft face, cleft lip, cleft palate, present a unique challenge to us. So if we were caring for a child with one of these facial malformations, it definitely increases the likelihood that we're going to have a difficult or a failed airway if we needed to provide positive pressure ventilations or secure that airway. If you decide to do mission work or travel, these children of this age with cleft facial malformations will be more prevalent than in the United States, where given our healthcare system, they're usually recognized early and repaired. Cleft facial malformation occur during embryonic development, and this can include the mandible, the maxilla, the lip, the palate, the nose, the cheek, or the eye. They can appear separately or together. Surgical correction is done as soon as possible to minimize nutrition and eating problems, to decrease ear infections, and to maximize normal speech development and communication. Patients who have barriers to accessing healthcare may not be able to achieve closure as an infant or a child. And there are national travel mission groups that will travel across to third world countries and perform surgeries for free. Cleft lip is closed using this multidisciplinary approach. So typically we start off with splinting or bringing the two pieces closer together to kind of stretch the skin and get the face used to being in normal alignment. And then we have our surgeons, so our maxillofacial and oral surgeons. Here, the device that you see on the picture on the left is called a Logan's bow, and that helps decrease pressure on the surgical site after surgery. So it basically stops them from being able to stretch or spread the top lip. They will have nutrition and dietary consult. They will have social services, occupational therapy, physical therapy, speech therapy, primary care, as well as their surgeons. It's really important that when you're thinking about destination determination, that you choose the destination that's most consistent with the immediate needs of the child. So if this child has received all of their care at a specialized hospital because of their cleft lip, but they fell on the playground and broke their arm, you should take them to the nearest ED rather than transporting them further away to a place that specializes in cleft lip, cleft palate. If you have a child, though, who's had a surgical repair and they fall and it breaks open, that's when you would talk to medical control about going to a different hospital so that they would go someplace where it could be repaired. With cleft lip, closure usually occurs between 2 and 3 months of age. And the closure of the lip defect is done prior to correction of any palate defects. So prior to closure, again, children are at risk for ear infections, so otitis media. And the reason that they try to close these at 2 to 3 months of age is one, it doesn't require immediate closure, so the risk of using anesthesia is lower as the child gets slightly older. But then two, we want to close it and repair it prior to speech development to help minimize any speech problems or diction problems. And again, the suture line is protected with a Logan bow or other splinting, and sometimes after surgery the child will also be in elbow restraints, which are splints that are placed on the elbows that stop them from being able to bend their arms and touch their face. So this is just kind of a picture timeline of a child who had repair, and you can see that these repairs are very effective, and over time, there's really minimal scarring. Surgical correction of the cleft palate is typically done between 6 and 12 months of age, and this is again related to waiting for normal growth of the palate. These children will have speech development delays, and communication may be delayed or impaired as well. During this time, the child requires feeding modifications, so nipples that don't require sucking from a bottle, or spoons, special cups and bottles. But you can see here, if the defect is in the palate, it allows for transmission of food up into like the nasal cavity and the sinuses. So we worry about infection a lot. And so just, to recognize that this increases the risk of ear infections as well as choking and aspiration. All right, so moving on then to gastroenteritis. Vomiting and diarrhea in children is a concern because of fluid and electrolyte imbalances. And this can be caused by viral infections that are usually self-limiting and require just symptomatic support. So we talk about sips and pops in kids, where we just want them to take, a sip or a spoonful of something, or use a popsicle, so that they're just getting kind of a constant trickle of fluid rather than a bolus of fluid into the GI tract, and that will help prevent dehydration. Kids do need sugar and salt added in, so things like juices and popsicles and stuff are a good idea. We want to monitor really carefully for fluid volume deficit or dehydration and fluid imbalance issues in the infant. Remember that hypoglycemia and hypothermia go hand in hand. So if the child is dehydrated enough that they're entering a hypovolemic shock state, we also want to keep a really careful eye on their glucose levels. And we should always check a glucose on any child who's dehydrated, especially if it's from vomiting and diarrhea, because they don't have adequate PO intake. Food intolerances can also cause spitting up or some vomiting, but mostly diarrhea. If there's a change in infant formula, it takes the baby's GI tract about 7 days to adapt to the new formula. And if the breastfeeding person, so if the baby's breastfeeding, the person who's doing the breastfeeding, if they ate something that crossed into the breast milk and the baby is sensitive to it, then that also can cause diarrhea. So diarrhea from food issues or food intolerances tends to be liquidy and bright yellow-green stool. And we know that fluids are absorbed in the large intestine. So as your stool moves from the small intestine into the large intestine, the right lower quadrant, it's completely liquid. And then as it goes up towards your liver, and then across towards your spleen, and then down towards the rectum and out, water is absorbed and it becomes more and more formed. So when children have diarrhea, this really increases the potential for dehydration. Spitting up, though, in kids is completely normal, and this is a gastroesophageal reflux. It's not GERD, so it's not a disease. It's just a condition at this point in time, so it's just GER. And this is defined as any time there's a transfer of gastric contents into the esophagus. This occurs in everyone of all ages, but the frequency and persistency are what would make it abnormal. So if there was a child who was constantly refluxing after eating, that concerns us because they could aspirate that and then end up with pneumonia. Also, as we reflux gastric contents, there's all that acid that can, in adults, it causes Barrett's esophagitis, and in children, it also can cause cellular changes. So we know that the incidence of reflux increases in children who have neurological impairment, hiatal hernias, esophageal atresia that's been repaired, or obesity. And when we think about, that kind of constant spitting up, that's different than actual vomiting. So again, just, good assessment, think about fluid volume balances. Appendicitis is an inflammation of the appendix, and the vermiform appendix is off of the large intestine and the cecum, so where the ileum comes into, so the small intestine comes into the large intestine, that right lower quadrant, that's where the appendix is located. The most common cause of appendicitis is stool obstruction that leads to a buildup of fluid secreted by the mucosa of the appendix. So a fecal lith or, constipation, a fecal lith is like a poop stone basically that can plug up the exit of the appendix that traps bacteria in there, and the fluid that's just normally secreted by the GI tract in there, and then it can get inflamed. The inflammatory process causes increased intraluminal pressure, so there's a buildup of pressure inside the appendix itself, and that leads to infection, abscess, necrosis, and perforation. It's most common in adolescents, young adults, and males. So the presentation is going to be a generalized pain in the upper abdomen or around the umbilicus, the belly button, and then usually over a day or so it migrates down and becomes localized in that right lower quadrant at McBurney's point. So you can see here in the picture that McBurney's point is 2/3 of the way from the umbilicus to the anterior superior iliac spine, right, or like that hip bone. So in that right lower quadrant, a little below the level of the umbilicus and off laterally. Rebound tenderness is present with appendicitis. You can check this by having the person go up on their toes and drop down to their heels. You can have them lift the right leg in the air, and engagement of the psoas muscle, which runs along the back of the pelvis, will irritate that as well. And then you can also jiggle the flanks. So anything that causes movement of the intestine, the large intestine specifically, is going to kind of jiggle or wiggle the appendix, and that will cause increased pain. So by definition, rebound tenderness is where you push in on something and it hurts, but when you let go, the pain is more severe from the movement of it. But in the field, because we don't have CAT scan, or we're not trained to do ultrasounds of pediatric appendixes, we really want to avoid deep palpation over painful areas of the abdomen, because if it is abscessed and we push too hard, it could perforate, and then that could cause peritonitis, which could become septic and life-threatening. Fever is very common as well, and just as a rule of thumb, their temp needs to be at least 100 to consider perforation. So if the child has a high fever with right lower quadrant pain, that increases our concern that it has perforated. Other signs and symptoms are nausea, vomiting, and anorexia related to the pain. You can follow your protocols for pain management and nausea management. Definitely want IV access for this child. Conservatively, we sometimes are just doing antibiotics rather than appendectomies. And then if the person does need an appendectomy because it's ruptured or it looks like it's abscessed, they oftentimes will try to wait to remove it until they've gotten antibiotics into the system to decrease the risk of infection from the surgery. So you may, have a family member or patient who has appendicitis that doesn't get it taken out right away or at all because conservative measures have shown to decrease infection. Other colon issues would be things like intussusception. Intussusception also can happen at the ileocecal junction. So this is where the intestine telescopes kind of into itself. Where the small intestine enters the large intestine, it can easily kind of fit inside that lumen. And so it just kind of goes inside, which you can see there in the picture. This causes severe abdominal pain that's intermittent with peristalsis. So as that area contracts or constricts to kind of push the GI contents forward, it causes really severe pain and pressure on the telescoped part, so the intussusception itself. Also, the other thing that we see with this is current jelly stools, so this kind of black mucousy or dark purple red mucousy stools. The treatment for intussusception actually usually is the diagnostic itself. So air enemas or barium enemas, when they do an enema, it goes up through the rectum, it goes up the descending colon, backwards across the transverse colon, and then down the ascending colon, and oftentimes the filling of the large intestine in reverse order pushes the telescoped part back out. Oftentimes we're able to correct it with either a barium enema or an air enema. If they can't, though, this is a surgical emergency. So anytime we have a problem with perfusion of the gut, it's technically a surgical emergency because ischemic bowel can become necrotic pretty quickly and put us into metabolic acidosis, which then can cause death. The other thing that can happen inside the intestines is called a volvulus, and a volvulus occurs when there's rotation of a loop or portion of the bowel that kinks off the intestines. And this then blocks passage of stool, so this person's going to have severe abdominal pain and no stool. And so this is what we would call a mechanical bowel obstruction. So there's an actual like physical or mechanical obstruction there. And this can cut off blood flow to the loop itself. Again, this causes ischemic bowel, which can cause massive metabolic acidosis and death. So all of these are considered surgical emergencies. GI bleeding in children is very uncommon. When present, it's usually from constipation and trauma to like the rectal tissues that bleed a little bit, or swallowing blood while feeding, like from bleeding nipples, or swallowing a lot of blood from like surgery, like tonsillectomy, or epistaxis, so a nosebleed. The most common congenital GI disorder in children is called Meckel diverticulum, and this can cause rectal or GI bleeding in children. You can see here in this picture where the ileocecal junction is, where the small intestine goes into the large intestine, that there's an appendix. And then Meckel's diverticulum is basically a secondary type of appendix. So that is this like little outpouching or diverticular pouch attached to the intestine. So the rule of twos says that this occurs in only 2% of the population. It's 2 times more common in males. It typically presents before age 2. It's within 2 feet of the ileocecal valve. It's at least 2 centimeters in diameter and 2 inches long, and it contains 2 types of ectopic tissue. So a child with abdominal pain and or rectal bleeding would get an ultrasound or CAT scan to look for Meckel diverticulum. Pyloric stenosis is caused by overgrowth of the pylorus, so it's also referred to as hypertrophic pyloric stenosis. This is a congenital defect that causes, or is caused by, I should say, enlargement of that circular pyloric muscle, which leads to constriction of the pyloric sphincter with obstruction of gastric outlet. So usually when you eat, food comes in through the esophagus into the stomach, and it's broken down with the gastric acid, and then the pylorus and that pyloric sphincter open and allow passage of food into the small intestine, so the duodenum and then the jejunum. When we have hypertrophy of the pylorus, it does not allow food to exit the stomach normally, and instead then the stomach kind of revolts and the patient will have projectile vomiting. So this is different than the cute little picture of the kids spitting up. This is really forceful stomach emptying, so projectile vomiting. And then as soon as they vomit, they are frantic to eat again because these kids are super hungry and they're not getting food into their body as they need. On exam, you might feel a palpable olive or walnut shaped mass kind of in the right upper quadrant or just to the right of midline. These children aren't getting adequate nutrition, so they lose weight. There's no evidence of pain or discomfort other than, the vomiting and the hunger. They oftentimes will be dehydrated, and because they're losing hydrochloric acid from vomiting stomach contents, they'll develop metabolic alkalosis. So that weight loss then can also lead to failure to thrive. This is the most common cause of infantile surgery and is usually symptomatic by a few weeks of life. And so once this is discovered, the child would be admitted to a hospital that has a pediatric GI surgeon, and they would repair this defect. So the repair for this is surgery, and the surgery is called a pyloromyotomy, and that essentially means I am cutting open the muscle of the pylorus. So you can see here in the picture how that pylorus was enlarged, and then basically they make an incision on the outside wall that allows the muscle to bulge outward rather than inward towards the sphincter. So what do you need to know about this? If you have a kiddo who has had correction of a pyloric stenosis and they start with projectile vomiting again, that's an emergency. So especially if the surgery was recently, because the vomiting could put excess pressure on the surgical site and cause bleeding. Hirschsprung's disease, or agangliotic megacolon, is a congenital defect that leads to a lack of innervation. So the ganglion cells in the colon and the rectum are not present, and so therefore the internal anal sphincter cannot relax, and they can't pass stool. We see this in about 1 of every 5,000 live births. It's more common in males than females, and the severity of it depends on the extent or number of ganglion cells that are absent. This causes a mechanical obstruction from inadequate motility of the intestine and the lack of anal sphincter relaxation. So what happens then is that area that you can see in that descending colon becomes really kind of distended, full of stool, and impacted, and then they leak this kind of ribbon-like foul-smelling stool around it. So they may be passing some stool, but it's very thin and foul smelling because it's literally just like kind of leaking around this big mass of constipation. Enterocolitis, which is an infection or inflammation of the intestines and colon, might occur. So watch carefully for fever, increasing abdominal pain, and diarrhea. This also can be surgically corrected. So pediatric patients who have certain congenital defects or medical problems may require assistance with feeding or elimination. So feeding supplementation can be done via a gastric tube. And for short-term use, this could be placed through the mouth or nose, so an NG tube or an OG tube. And for longer term, these are surgically inserted through the abdominal wall into the stomach or the intestines, so the duodenum, the jejunum, or further on down the intestine, depending on what the person needs. Sometimes these sites can get plugged, so if they crush medication and give medication through the tube, that can obstruct it, or sometimes if they're also eating, that can kind of back up into it and cause an obstruction. The site can get infected, they can bleed, or the child, or whatever, it gets caught on something and it gets pulled out. This picture is a Mickey button, which is flatter against the skin to decrease accidental pulling or removal of a device. You may have seen some adult feeding tubes that tend to be, longer and a couple inches outside of the abdominal wall. Caregivers often have replacement devices, and some are even trained to reinsert them if needed, but not when it's fresh. So if this child just had surgery, then that wouldn't be an option. But if the opening, just like when you pierce your ears, if the opening is well established, then it's actually usually fairly easy to reinsert these if needed. If though you go to one and it's out and they either don't have a replacement or they don't know how to do it, that's not something that you should try to replace or troubleshoot, but instead just cover the area with gauze to catch anything that's leaking out. If the child coughs or sneezes or bears down, whatever is in the intestinal lumen near that opening is going to come out. So my best advice is cover it, and they'll take care of it at the hospital. Some children require surgical creation of a stoma for urinary or fecal diversion. So they can have an ileal conduit, which is like a urinary diversion, or they can have an ileostomy, which is in the right lower quadrant, which is going to be just liquid stool, or they can have a colostomy, as you see here, which is in that left lower quadrant, and that's usually fairly formed stool. These stomas will always be on the abdominal wall. Another reason why it's so important to fully expose your patients. And again, the location of the device will change the consistency of the output of the stool. Children with ileostomies, so in that right lower quadrant, and chronic liquid stool have an increased risk of dehydration and electrolyte loss, really specifically potassium. So vomiting and diarrhea lose potassium. So our role in caring for a pediatric patient who has an ostomy, is to observe the stoma. It should be this nice beefy red color that you can see there. It should never be dark or dusky. It should never be pale. It should be moist looking, and then drainage again depends on the location of the ostomy. If you have an ostomy that looks like it's not getting adequate blood flow, so it's dark or purple or pale, that is a surgical emergency, and so get to the nearest appropriate facility. So overall, our management of pediatric patients with GI issues include, again, performing the pediatric assessment triangle from the doorway to determine severity of the condition, being methodical in our approach and doing our ABCDEs, obtaining a thorough and organized history, and then performing our physical examination. And we want to look for things that would tell us that there might be a GI problem, like jaundice or pallor, fluid volume deficit, so evidence of dehydration, fevers, rashes, or any pain on assessment of the abdomen. It's critical that you know your landmarks and the underlying structures, especially in kids that aren't old enough to communicate how they're feeling with you, and then treat abnormal findings as indicated. As always, thanks for watching, and we'll see you on the next one.